Alright, today we're going to be looking at joints, and mainly doing so for a review. So first let's look at the structural classification of joints. There's fibrous joints, cartilaginous joints, and synovial joints. Fibrous joints and cartilaginous joints are made of fibrous tissue and cartilage tissue respectively. And they both do not have a joint cavity and are mainly synarthrotic or not movable. Synovial joints are made up of many components like articular cartilage, ligaments, tendons, synovial fluid, but the big thing that synovial joints have is a joint cavity. So when we're talking about what these joints are made up of, that's their structural classification. But we can also look at the functional classification, like the fact that fibrous and cartilaginous joints are synarthrotic, or don't really move too much. You have the gomphoses, or a peg and socket joint of a fibrous joint between your tooth and its socket, ligaments like syndesmoses, and fibrous tissue between skull bones like sutures. And then you have the synchondroses or hyaline cartilage joints, or symphyses, fibrocartilage joints. All of these don't really have movement, but they do attach bone ends together. Now when we're talking about synovial joints, they're not synarthrotic. They are actually diarthrotic. Diarthrotic joints are freely movable, and most of the limb joints, so most joints of the body, are diarthrotic because they're synovial joints. So when you're talking about structural and functional classification, we want to separate what a joint is made up of, structural, from its functional classification, how it moves. There's also another classification besides synarthrotic and diarthrotic, and that is amphiarthrotic. Amphiarthrotic means slightly movable. And for really long ligaments, or longer syndesmoses, we might see a little bit of gliding, and so that might make some fibrous joints amphiarthrotic. Here we can see the parts of a synovial joint. You have the articular cartilage and the articular capsule, which form the boundary around the joint cavity. The joint cavity is the main component or characteristic of a synovial joint, and it's filled with synovial fluid. The inner synovial layer of the articular capsule makes the synovial fluid, which is a thin fluid that reduces friction between the articulating bone ends. The outer layer of the articular capsule, though, is really there for support. Also not pictured are reinforcing ligaments and nerves and blood vessels, which are often present. There's also other friction-reducing structures, like bursae, flattened fibrous sacs lined with synovial membranes, and they contain synovial fluid as well. And tendon sheaths that are elongated bursa that wrap completely around a tendon. Both of these structures are common where ligaments, muscles, skin, tendons, or bones rub together. We want to prevent structures like that from rubbing together because that produces friction and then heat. So these are also friction-reducing structures, and both also contain synovial fluid in order to do so. You can see in the image on the right the bursa under the acromion, so that's called the subacromial bursa. And that's a flattened sac between a tendon near the acromion and some of the muscle on top of the humerus. Then you can see the tendon sheath, where the tendon sheath is acting kind of like the hot dog bun if the tendon was a hot dog. And that's there to kind of prevent that tendon from rubbing against bone and producing heat. We also want to talk about when are joints stable, especially synovial joints. Synovial joint stability is determined by three factors: how well the articular surfaces fit together, if ligaments are present, and if muscle tone is active and available. When the articular surfaces fit together well, then the bone is more stable. And that means the joints that are coming together to make that bone structure are more stable. And ligaments are going to provide strength, and ligaments unite bone to bone, and they're there to prevent excessive or undesirable movement. But definitely the most important part of synovial joint stability comes from a muscle tone specifically. Muscle tone is when you have slight contraction of muscle, so it's ready and active and available when it needs to contract. And muscle tendons across joints act as stabilizing factors due to this muscle tone in the muscles they connect. So tendons are always kept tight by muscle tone, and tendons unite muscle to bone. So speaking of muscle tone, we want to look at the attachment by tendons of muscles to bone, because it's the contraction of that muscle via tendons that creates that muscle tone that helps stabilize synovial joints. Keep in mind that these tendons are attached to bone in at least two locations. The two muscle attachment points would be the origin, the attachment to the immovable bone, and the insertion, the attachment to the movable bone. Imagine doing a bicep curl or bending your elbow. The attachment point for the biceps brachii muscle on your radius in your forearm moves in space because that attachment point is going to be the insertion. And your forearm bone moves towards the other attachment point, the origin, that's located on the scapula, which doesn't move in space when doing a bicep curl or bending your elbow. So when we're talking about muscle tone and muscles and tendons, we have to take into account multiple things. And later on you'll learn more about muscles and their actual contraction and the difference between tension and contraction. But for right now, we're just looking at them as ways to move the skeleton at joints. We also want to talk about synovial joint movement. So some joints have non-axial movement. They glide or slip, but they don't really move. Others have uniaxial movement and can only perform things like flexion and extension, and we'll look at motions like that. Then biaxial is movement in 2 planes, and multiaxial is movement in all or around all 3 planes. The 3 general types of movements we're going to see are slipping and gliding, angular movements, like bending your elbow and straightening out your arm, and rotation, like turning your head left or right for no. So when we're talking about 2 flat bone ends or cube-shaped bones coming together, that's when we see gliding. Imagine waving at someone and the bones in your wrist are visible. You would see them slip and glide past each other. Then you have angular movements, like decreasing the angle between articulating bones, that's flexion, or extension, increasing the angle between articulating bones. Flexion and extension are opposites of each other, and a good example of flexion is bending your arm at the elbow. A good example of extension is straightening your arm at the elbow. Then you have abduction and adduction. For abduction, you're moving your limb away from the body's midline, such as raising your hand. For adduction, you're moving your limb toward the body's midline, such as kind of the second movement in jumping jacks. And for circumduction, you're making a cone in space using your upper or lower limb, and that involves flexion, extension, abduction, and adduction. And then you have rotation, which is pivoting a bone around its long axis, and you can also do medial and lateral rotation. Even though you see rotation the most for the joint between your first 2 cervical vertebrae, when you turn your head left or right, you're using this joint. You can also medially or inwardly rotate your shoulders and your hips, or laterally or outwardly rotate your shoulder and your hips. There's also special movements like pronation and supination. Pronation is medial rotation of the forearm. So you would have your palm facing up and then turn it facing down. So that would be performing pronation. Then supination is lateral rotation of the forearm. So you have your palm facing down and then turn your palm facing up. That's supination. Inversion is medial rotation of the ankle, or turning your ankle inward towards your midline. Eversion is lateral rotation of the ankle, or turning your ankle outward away from your midline. Then there's depression, like opening your mouth, or lowering your shoulders. Or elevation, like closing your mouth, or shrugging your shoulders. Protraction is jutting your mandible or your jawbone forward past your upper lip. Retraction is pulling your mandible or jawbone backward behind your upper lip. And then you have dorsiflexion and plantar flexion, where we return to your feet. Pointing your toes toward your shin or upward is dorsiflexion. Pointing your toes away from your shin is plantar flexion. You could also say that plantar flexion is pointing your toes towards the ground. And then opposition is when you touch your thumb to the tip of any of your other fingers. Here are a couple of images showing synovial joint range of motion. For example, lowering your chin to your chest is flexion. And then going from having your chin at your chest and looking upward is extension. You can also create a cone in space or perform circumduction with your upper or your lower limb. You can bend your knee, which is flexion, or straighten out your knee, which is extension. And you can perform multiple versions of extension and flexion and other angular movements with things like your hip. So just keep those in mind and think about the ways you move in space. Next, we want to look at types of synovial joints by combining shape and their movement capability. And there are 6 different types of synovial joints. Again, what we're combining is the shape of the meeting bone surfaces, called the articular surfaces, and the movement of the joint. What can it do? For example, plane or planar joints only show slipping and gliding. Think of the cube or kind of short bones that have flat surfaces that meet, and they only show slipping and gliding, so that's a planar joint. Hinge joints are going to have a cylindrical structure that fits into kind of an open concavity that looks more like an elongated trough. Hinge joint examples include the elbow, and it's only capable of flexion and extension in the sagittal plane, so it's uniaxial in its movement. Pivot joints are also uniaxial in its movement. They can usually only show medial and lateral rotation. Then we have condylar, which show biaxial movement, and saddle, which show biaxial movement. Both condylar and saddle joints contain a convex and concave shape that fits together. The convex and concave shape for a saddle joint is just a little bit more elongated and saddle-shaped. Both condylar and saddle joints can perform flexion and extension and rotation. Also abduction and adduction. Now, when it comes to ball and socket joints, they're really the only synovial joint we see that has multiaxial movement or is really completely diarthrotic. So it's the most freely movable joint of the body. With a ball and socket joint like the shoulder and the hip, you would see a ball-like structure at the head of a bone, articulating with a cup-like cavity on another bone. So we can actually look at ball and socket joints, like your shoulder, also called your glenohumeral joint, or your hip. So your shoulder and your hip are great examples of ball and socket joints, but they are different. Your shoulder has a shallow socket, really poorly articulating bone ends. They don't fit well together. It has a weak joint capsule, but it does allow for a lot of mobility because of that structure. But it mainly has to be held together by ligaments, tendons, especially the tendon of the biceps brachii, which we consider the super stabilizer for the shoulder. Then we have the hip. The head of the femur and the acetabulum of the pelvis fit very well together. So this is a ball and socket that's actually going to have really strong articulate surfaces, but that does sacrifice some of its mobility. It's not as movable as the shoulder. It's also held in place by a strong joint capsule and really large ligaments and tendons. Other joints we can look at are the elbow, which is located between the distal end of the humerus and the proximal end of the ulna. So forearm bones and the upper arm bone coming together. It has uniaxial movement, is a great example of a hinge joint, and only allows for flexion and extension. There's also the TMJ, or temporomandibular joint, held together by a weak and shallow joint capsule and easily dislocated. It's made up of the articulating surfaces of the temporal bone and the mandible. And then the knee, which is actually 3 joints in one. A joint between your femur and the patella, and then 2 joints between the lateral and medial side of the femur and the tibia. It also contains cartilaginous padding called the meniscus, and also collateral and cruciate ligaments. These are there to prevent over-exaggerated movements, so we can really just see flexion, extension, and some rotation from the knee. But hyperextension or horizontal blows are going to make the knee very vulnerable and likely to experience things like cartilage damage or damage to ligaments and tendons. So speaking of joint injuries, when cartilage is damaged, usually commonly by anaerobic activity, it's generally going to require arthroscopic surgery to repair because it's not well vascularized, it doesn't have blood vessels, so nutrition and repair are very hard for cartilage on its own. Sprains, though, they're just going to occur when reinforcing ligaments are stretched or torn. Of course, being torn are much more common, and especially with dislocations. Dislocations occur when bone ends are forced out of alignment, but sometimes they're not completely pushed out of alignment. Instead, it's just a subluxation or a partial dislocation. Either way, both dislocations that are complete and subluxations can come with pain, swelling, inflammation, and joint immobilization. Then there's bursitis and tendinitis. The bursa and the tendon sheaths can become inflamed, and both usually become inflamed from either a blow or friction, some type of trauma. And symptoms include pain, swelling, and treatments that are recommended are anti-inflammatory medication, and sometimes even synovial fluid aspiration. We can also look at other conditions that affect joints, like arthritis. Osteoarthritis, for example, is wear and tear arthritis, much more common in the elderly, but anyone can have osteoarthritis. Treatments include anti-inflammatory medicine, physical therapy, and continuous light movement. Now, osteoarthritis is likely to affect everyone as they age, but some are more affected than others. So, continuous movement, not becoming too sedentary, are ways you can try to help prevent different types of OA. Then we have rheumatoid arthritis. RA is an autoimmune condition, meaning that the body is attacking itself. With RA or rheumatoid arthritis, this autoimmune condition affects the joints, but could also be associated with cardiovascular issues, muscle atrophy, anemia, and even osteoporosis on top of joint tenderness and pain. So treatments include anti-inflammatory medicine and sometimes even immunosuppression. But if it goes untreated, the bones can ankylose or fuse together, like you see in the image on the right. It commonly affects the hands, the vertebrae, and sometimes the feet. Then there's gouty arthritis, which is caused by the deposition of uric acid crystals in joints and soft tissues. And generally this is followed by an inflammatory response around that soft tissue and where the uric acid crystals deposit. Now, treatments include steroids and also avoiding foods high in uric acid like lunch meat. Now, all of these conditions do have a slightly genetic component, but there are other factors that can dictate their outcomes, and all of them can be treated with anti-inflammatory medicine. For some, though, that may not be enough. And then last but not least, we're just going to look quickly at Lyme disease, which is actually caused by bacteria transmitted by tick bites. And its symptoms include joint pain and arthritis, but not always. The more common symptoms are a bullseye skin rash, flu-like symptoms, and brain fog. But the treatment is a really long course of antibiotics, anywhere from a couple of weeks to 6 months to a year. It's best treated immediately after the tick bite if you note that bullseye rash. Also keep in mind, here in Georgia, a bullseye rash may be the symptom of a brown recluse bite. But be aware for both, and it wouldn't hurt to seek out medical attention and to ask your primary physician if you see that bullseye rash. All right, that's going to be it for Chapter 8 review. So make sure to go back and get familiar with all those terms, especially things like synarthrotic, amphiarthrotic, and diarthrotic, the functional classification of joints.